Welcome to today's webinar by the Paediatric Renal Nutrition Task Force, hosted by VitaFlow, titled Assessment of Nutritional Status in Children with Kidney Diseases. My name is Lucy Evans and I work as a Global Marketing Manager at VitaFlow International Limited. I'm also a dietitian by background. This webinar forms part of a series from the Paediatric Renal Nutrition Task Force, which will run throughout 2021. Further details of this will be discussed at the end of this presentation. The paper, which is referred to in today's session, titled Assessment of Nutritional Status in Children with Kidney Diseases, Clinical Practice Recommendations from the Paediatric Renal Nutrition Task Force, is published in Paediatric Nephrology. A link to this paper has been posted in the chat box for you to access. A link to the paper can also be found on both the VitaFlow VIA website and the European Society of Paediatric Nephrology, or ESPN, website. The paper is available via open access. This webinar is intended for healthcare professionals only. The webinar will last approximately 1 hour and 30 minutes, which includes dedicated time for a question and answer session in the last part of the webinar. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened, with as many questions as possible being asked by the speakers at the end of the presentation. A practical guide and case study will be discussed during the webinar. You will find the practical guide and the worksheets relating to the case study in the handout section of the toolbar. These can be downloaded for you to use. You can also access a certificate of attendance here. The webinar is being recorded and will be available on the VitaFlow VIA website in approximately 1 week. The views herein are of the presenters and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and is for educational purposes only and not intended as a substitute for medical advice. You will see the learning outcomes on the next slide, documented here, which we hope that you will achieve through watching the webinar. So without further delay, let me introduce our speakers for today's webinar. So VitaFlow is delighted to introduce Dr. Ruxana Shroff, Professor Bradley Warraday, Caroline Anderson, Christina Nelms, and Vanessa Shaw. Vanessa Shaw will be chairing the webinar alongside Dr. Ruxana Shroff. Vanessa is an honorary senior lecturer at University College London and Great Ormond Street Hospital Institute of Child Health in London. Vanessa was head of dietetics at Great Ormond Street Hospital for Children until 2017. She was awarded a national honour, an MBE, for services to children's healthcare. Vanessa is a reviewer for Paediatric Nephrology and the Journal of Renal Nutrition and is co-chair of the Paediatric Renal Nutrition Task Force. As well as serving on many government committees, including the Panel on Child and Maternal Nutrition and the Advisory Committee on Borderline Substances, Vanessa is also the editor of Clinical Paediatric Dietetics, the seminal text for paediatric dietitians in the UK and overseas, now in its 5th edition. Vanessa is committed to the education and training of dietitians, establishing the unique master's course in paediatric dietetics, a partnership between the British Dietetic Association and the University of Plymouth, where she was honorary associate professor until January this year. So to begin our seminar today, Dr. Ruxana Shroff will give an introduction to the Paediatric Renal Nutrition Task Force. So Dr. Shroff is a consultant in paediatric nephrology at Great Ormond Street Hospital for Children in London and associate professor at University College London. Her research focuses on bone and cardiovascular disease in childhood chronic kidney disease and improving outcomes for children on dialysis. Ruxana holds a prestigious senior fellowship from the National Institute for Health Research. Ruxana is co-editor for the 8th edition of Paediatric Nephrology, the definitive textbook in our field. She was elected to serve as a member of the KDIGO Kidney Disease Improving Global Outcomes Executive Committee and works on international guideline committees for KDIGO, NICE and ESPN. She serves on the editorial board of several journals and has published over 200 original articles, reviews and editorials. Ruxana has contributed to the scientific committee of several international meetings. So now it's with my pleasure I will pass over to Ruxana to present.
Vanessa, thank you very much, Lucy. And on behalf of Vanessa Shaw and myself, I'd like to welcome you all to the Pediatric Renal Nutrition Task Force and our first webinar here. So, about 3.5 years ago, we came together as a group of dietitians and doctors to bring this to try and build this team. The reasons we did this are the challenges and inconsistencies in the nutritional management of children with kidney diseases, not just here in the UK or Europe or the US, but globally. We identified the importance of nutrition in patient care, which really should not be something I have to tell this audience, but something that is not addressed in our medical education. And many renal centers around the world do not have trained renal dietitians. We are a group of doctors and dietitians from 8 countries around Europe and in the US and Canada. And our team is endorsed by the European Society for Pediatric Nephrology and the International Pediatric Nephrology Association. Our vision is to ensure best practice in the nutritional management of children with kidney diseases. And to do this, we have set about going through a few mission processes. So we have formulated clinical practice recommendations to enable best practice, to provide education and training resources for healthcare professionals who care for children with kidney diseases. We've devised resources which offer practical support to children with kidney diseases and their families. And lastly, we hope to promote research in this field and expand the evidence base for nutritional intervention in pediatric kidney diseases. We are committed to having an open and transparent policy of discussing our guideline development process with our colleagues and our team members. And we work inclusively with doctors and dietitians who are our main stakeholders, as well as, of course, parents and children and their caregivers. So, in the 3.5 years or so that we have been a team, we have got 5 guidelines that have been developed, and sort of in chronological order of them appearing, we have guidelines on the dietary management of calcium and phosphate in children with chronic kidney disease, energy and protein requirements for this same group, the delivery of the nutritional prescription by enteral tube feeding, the assessment of nutritional status in children with kidney diseases, which is the topic of discussion today, and finally, our most recent guideline on the dietary management of potassium. 2 other guidelines are under development and close to being completed now. And we are always looking for more ideas and to welcome people on board to join us in this. So our guideline development process includes formulating relevant questions which follow the PICO guideline. This is patient, the population, intervention, comparator, and outcome. So, just to give you an example, and deliberately not to use the example from this particular guideline discussion today, for if we look at the guidelines, say for calcium and phosphate management, we'd look at the population of children from birth to 18 years of age with chronic kidney disease stage 2 to 5 and on dialysis. The intervention considered would be the nutritional requirements of calcium and phosphate in children at different stages of CKD. The comparator are nutritional requirements in healthy age matched controls. And the outcomes would be a whole bunch of things, including their growth, bone mineralization, bone disease, fracture risk, calcium balance studies, hyperphosphatemia, hyperparathyroidism, risk of hypercalcemia, and vascular calcification. Now you see here that most of our outcomes are biochemical measures, but there are no real patient level outcomes, and there is very little data in this field. Each of our guidelines is produced only after a very thorough literature search, looking at electronic databases, including the Embase, Medline, Cochrane, PubMed, and of course also reviewing articles and recommendations from other groups. This is just an example of the mesh terms we search for and the thoroughness of our literature review. Also, all our statements are graded, and we follow the American Academy of Pediatrics grading recommendations in order to do this, so that the reader knows the level of evidence available and therefore the strength of our recommendations. Finally, we include something called the Delphi process. And here, doctors and dietitians around the world are sent a questionnaire for each clinical practice recommendation and asked to mark each statement in it along a scale of strongly agree, agree, neutral, disagree, or strongly disagree. And we encourage people to give us their feedback and the reasons they made these comments. We aim for at least 70% overall consensus before a guideline can be deemed acceptable. And really, the reason for this is the very low level of evidence we have for most of our recommendations. So we know that many of these are expert opinion, but we do want it to be the expert opinion of a large group of people and not just a personalized experience from one or two people. Uh, uh, the dissemination is a very key important part of our work, and you will see documents like this come out with each of the guidelines we produce to give the stakeholder, the healthcare professional, the dietitians, and eventually also the parents and caregivers an idea of how to implement the guideline. Finally, all our work is available on our website, both at the ESPN and the VitaFlow website. So with this, I'd like to hand over now to Professor Brad Warady, who has led the first guideline on the clinical assessment of children with kidney diseases. He's a professor of pediatrics at the University of Missouri, Kansas City School of Medicine, and director, Division of Nephrology at the Children's Mercy, Kansas City. Professor Warady serves as a co-principal investigator of the NIH-funded Chronic Kidney Disease in Children, the CKID study, and also the International Pediatric Dialysis Network. He's vice president, board of directors of the North American Pediatric Renal Trials Collaborative Studies, the NAPRITICS, and he's also on the national board of the board of the National Kidney Foundation. He's an executive committee member of the International Pediatric Nephrology Association, and he has served on the writing committees of the NKF-KDOQI, as well as several other guideline groups for peritoneal dialysis adequacy, bone management, and nutrition. And he has co-edited several textbooks in different fields and published over 500 articles and book chapters. Thank you, Brad, and over to you.
Thanks much, Roxana. Hello, everybody. Okay, so as Roxana mentioned, and Lucy did as well, we're going to talk about the assessment of nutritional status in children with kidney diseases today. And I'm going to initiate the discussion by reviewing for you all of the clinical practice recommendations that have been generated by the task force with some rationale behind some of the recommendations. Just as a background slide, this is data that was published in 2019 by the International Pediatric Dialysis Network on the regional variation of nutritional status at the start of chronic peritoneal dialysis. So this data obviously reflects the nutritional management during CKD around the globe. And as you can see, while the vast majority of children have a normal weight as reflected by the green bars, there's also a substantial percentage of children that are either malnourished, overweight, or obese. And so this data clearly highlights the fact that nutritional management is a key aspect of the overall management of children with CKD. Now, for those of you who have only been in this field for maybe a decade or more, this is really what I think is the first publication that addressed on a global basis the nutritional management of children with chronic kidney disease. This was from the KDOQI initiative, published in the year 2000 in the American Journal of Kidney Disease. Subsequently, in 2009, we significantly enhanced that document, if you will, and published this document also from KDOQI, which really addressed in depth the nutritional management of children with CKD. And I think the current task force now has taken this core document, expanded it, and made it very practical and really updated it, if you will, to, again, address the issues that we're going to be talking about today. And this is the publication that Lucy has already referred to on the assessment of nutritional status published by the task force. So when going over the clinical practice recommendations, they're really in three different groups. anthropometric assessment, dietary assessment, and biochemical assessment. So CPR 1.1 states we should be measuring the weight, height, or length and head circumference in children with kidney diseases. We need to look at or aim to determine the euvolemic or dry weight, which, as we know, can be challenging in our population because we have children that are on dialysis, some with nephrotic syndrome and peripheral edema, and so on. When we're looking at the children that are less than 2 years of age, we should be measuring their recumbent length and standing height thereafter. For the very young children who are unable to stand for an accurate height, the recumbent length can be measured. And for older children who are unable to stand, we should be utilizing a surrogate measurement for height for those children. And because the head circumference can also be a reflection of the nutritional status, we should be measuring the head circumference in all children up to 2 years of age or up to 3 years of age when appropriate charts are in fact available. So let's talk about the weight measurement. These are the considerations that one should keep in mind in terms of the assessment of the euvolemic or dry weight. Obviously, you're going to have your weight that you measure. We need to look at for the presence of edema and look at the blood pressure. Clearly, individuals who have evidence of peripheral edema or have high blood pressure may be hypervolemic and may not be at their dry weight. I think we also need to look at the laboratory values. So children who are hypoalbuminemic, have low hemoglobin values, or have hyponatremia, this may be a reflection again of hypervolemia and again the child not being at their dry weight. And then we need to look at the dietary interview to see if the interview data is again consistent with the dry weight. Now, children who are on dialysis have a special category here, and we have to look at them in a little bit different way. For the children that are on PD, we should generally be weighing them at their monthly visit. And for those who are receiving continuous cycling peritoneal dialysis, or CAPD, we need to remember to account for the intraperitoneal fluid that is there and subtract that when assessing what their dry weight is. And for those children that are on hemodialysis, ideally we should be obtaining a midweek post-dialysis weight and also taking into consideration the data from the non-invasive blood volume monitoring and vascular refilling rate to help us assess what their euvolemic or dry weight is. In terms of the standing height or recumbent length, the subject's eyes and ears should be parallel for the measurement. Clearly, we need to remove any hair accessories or headpieces. And importantly, the child should have their heels, their buttocks and shoulders flat against the length board in the case of an infant, or a wall-mounted stadiometer in the case of the older child. This table is also in the guidelines, and this table allows one to look at sort of a template in terms of the frequency with one should be measuring these anthropometric variables in the children. And so you could see that we have 3 different components to this table. One is looking at the difference in age, 0 to 1, 1 to 3, or greater than 3 years. The minimum interval with which these measurements should occur, be it weeks or months. And then you can see it's differentiated based upon the stage of CKD of the children. And Carolyn will go into this in greater depth, but I think this gives you a minimum approach, if you will, in terms of the metrics to be evaluated and the frequency with which they should be evaluated. Now moving to CPR 1.2, we should plot the anthropometric measurements serially on centile growth charts. We should use the WHO growth charts for all ages or country-specific growth charts if available beyond 2 years of age. We should always be calculating the z-scores or the standard deviation scores to complement the growth chart data. And again, the z-scores allows us to compare the data from our children to healthy children of the same gender and age. We should also be calculating the height or length velocity z-scores. That's important because we don't want to just look at snapshots of their growth, but really the movie, if you will, of their growth. And for those children that are more than 2 years of age, that height velocity data should be accumulated over a minimum period of 6 months. Now, some of the children we see will have underlying genetic disorders, and in some situations, there may be growth charts specific to that disorder. And if that's the case, one should be utilizing those growth charts. And then finally, like in all of pediatric nephrology, we should utilize trends in growth parameters to assist clinical decision making as opposed to single evaluations. So I mentioned to you the WHO growth data, and these are truly the WHO child growth standards. Now, this is why we're talking about standards as opposed to reference curves. So in 2006, the WHO published these international growth charts based upon data collected from over 8,000 children from birth to 5 years of age. Now, as you can see, this is truly an international group of children because you can see the various countries that these children resided in. And these children were all in ideal situations, if you will, in terms of growth. They were all breastfed, appropriately weaning foods. They had good pediatric health care. All of them received their immunizations, and they were in an environment free of conditions limiting growth. So because they were in this ideal situation, that's why we say that these represent growth standards versus growth references. And this is the data. Here we're looking on the left side at the mean of length, and on the right, the mean of height for children from birth to 5 years of age from, again, 6 different countries. And you can see that the results are near identical. So this really is the standard of growth for our kids through the first several years of life. And so if one goes to the WHO site, one can find a wealth of curves to utilize. And this is the length for age for girls. And you can see here we're looking birth to 2 years of age. These are the percentiles. And then this is an accompanying chart looking at, again, length for age for girls, birth to 2 years. And these are the z-scores, or standard deviation scores. And then this is the height for age for girls, 2 to 5 years of age, z-scores. And then here's a weight for age for girls, birth to 2 years of age, percentiles, and the accompanying chart looking at birth to 2 years z-scores. As I mentioned, head circumference is also a very important parameter to measure, and this is, again, the WHO data for the z-scores of children, boys in this situation, birth to 2 years of age. Now, I mentioned to you again, in some situations, there will be disorder-specific growth charts, and this is a growth chart of children with Turner syndrome, as you can see coming from the MAGIC Foundation, and there are also growth charts for premature infants, for children with Down syndrome. So again, one can look at other sources for disorder-specific growth charts and utilize them in those situations. Moving now to CPR 1.3, we should be calculating the body mass index, or BMI, in children aged 2 years and older, and weight for length in children younger than age 2. And again, most of the literature, when we look at the younger children, those 0 to 2, have utilized weight for length as opposed to BMI as the standard, and then again, BMI for those children more than 2 years of age. We should, again, plot BMI or weight for length on centile growth charts, and we should determine the z-scores, or the standard deviation scores, to complement the growth chart plots. A special situation is for those children who are very short. And as you can see with 1.3.3, we recommend using the height age for determining the BMI z-score or standard deviation score if the child is shorter than the 3rd centile curve on the growth chart, provided the child has not reached their adult height. And we'll go into that a little bit more in a few moments. And Chris will also talk about that when she talks about her clinical case. So BMI. So this is an important parameter that we obviously all should be looking at. And this is, I think, one important piece of data from the year 2000 published by Craig Wong, where he utilized data from the United States Renal Data System to look at the relationship between BMI, standard deviation score, and patient mortality. And you can see that there was a U-shaped relationship. the lowest mortality was seen in association with a BMI standard deviation score of plus 0.5. And for every one standard deviation score, positive or negative, the relative risk of mortality increased by about 6%. Now, this is not causal, it's just an association, but I think it again reflects the importance of assessing the BMI in our children with CKD and on dialysis. And so again, if you go to the site of the WHO, this is the weight for length for boys. And again, remember, weight for length is what we should be emphasizing in the younger children. And this is children from birth to 2 years of age. And these are the Z-scores. And the WHO also has very nice tables, simplified field tables, as so-called, which again address, in this case, the weight for length for boys, looking at their Z-scores. And the WHO also has, again, curves on BMI. Once again, we don't generally recommend BMI as the metric for the younger children, but BMI growth charts do exist, as you can see here, for birth to 2 years of age. These are the percentiles. And then these are the Z-scores as well. And then for older children, those 2 to 20 years of age, this is, again, a BMI chart. Now, BMI, I think, as everybody knows, is calculated in this manner: a weight in kilogram over height in meters squared. And so for the very short children, you could see how that will alter the calculation of body mass index. And so once again, keeping in mind that height and age and maturation are well associated, for the very, very short child, it's probably not appropriate to be comparing them to individuals of the same gender and a more normal height. And so in that situation, again, we recommend that we be expressing the BMI relative to the height age. And keep in mind, the height age is the age at which the child's height is at the 50th percentile. And that, again, will account for the fact that many of our children who are very short are probably also sexually immature, and again, are probably best compared, if you will, to those individuals of a younger age. Now let's move on to anthropometric assessment CPR 1.4. This states that we should be calculating the mid-parental height and plot that value as a centile to estimate the growth potential. And it's generally plotted at about 18 to 20 years of age on the growth chart. Based upon data from the UK for premature infants, we should be plotting the weight, the length, and the weight for length for both gestational and chronological age for the first year of life for those children born from 32 to 36 weeks of gestation, and through 2 years of age if the child was born prior to 32 weeks of gestation. And then finally, we should be monitoring the growth parameters routinely in children with kidney diseases with an increased frequency in the youngest children and those with advanced CKD, with comorbidities, with risk factors for poor growth, and in those not meeting nutritional and growth targets. This is the calculation of the mid-parental height. So for boys, we'll be taking the mother's height and adding 13 centimeters, add the father's height and take the average. And then for girls, we take the mother's height, adding the father's height minus 13 centimeters and take the average of those as well. The value that is obtained from these calculations, again, will be the anticipated final adult height for these individuals, so it allows you to take the genetic potential into consideration. And if we take 3.5 inches or 8.5 centimeters on either side of this calculated value, that represents the 3rd to the 97th percentile for that population. So it does give you some additional information on the genetic growth potential for these children. I show you this chart again because, again, it just emphasizes the importance of the frequent assessment and the fact that we're going to assess these metrics more frequently in those individuals who are younger and in those individuals who have more advanced CKD, and for those individuals who are not meeting the nutritional and growth outcome metrics. Now, in terms of dietary assessment, CPR 2.1 states the following: the dietary assessment should be guided by the severity of kidney disease and nutritional concerns, including abnormal growth parameters, excessive or inadequate dietary intake, poor quality of diet, gastrointestinal symptoms, and abnormal biochemical values. And one of the metrics we should also be looking at as part of the dietary assessment is the appetite of the children. So in the guidelines, you will find this chart that looks at dietary intake and the recommended frequency of dietary intake. Once again, it's differentiated by the age of the children, the interval, be it weeks or months, and then again, the frequency, as you can see in the chart here, with a more frequent assessment for those children with more advanced CKD. And of course, we want to know what the expected daily weight gain when we're monitoring these children. And so this chart is also included that provides you with the expected daily weight gain for age of our population over the first 2 years of life. Now, interesting data that arose from the C-KID study addressed the issue of appetite. And this is a slide from that study where we looked at the correlation between appetite and baseline iohexol GFR. And you can see that appetite was characterized by the child or the parent as very good, good, or very poor or fair, as noted by the yellow bars. And you can see in the bottom here, we're looking at the relationship between the characterization of appetite and GFR. And you could see that if you focus on the very poor or fair characterization, that the percentage of children who characterized it as very poor or fair progressively increased as the GFR fell. And so clearly there is a correlation between the assessment of appetite and the GFR. What was also very interesting in that analysis of the C-KID data was the relationship between the characterization of appetite and the reported quality of life. So this is data looking at, again, that characterization of appetite and data from the PEDS-QL Quality of Life Survey, which looks at an overall score as well as the domains of physical, emotional, social, and school. And here we're looking at the parent report, because there's a parent report and there's a participant or child report. So if you look at the parent report, you can see that as the appetite characterization became more poor, you can see that in each case, the scores on the quality of life assessment became lower for each of the domains. And that was the case not only for the parents, but also for the children as well. So you can see again, as it went from very good to poor, the scores decreased for the overall score as well as for each of the domains. So asking about appetite is important not only from a nutritional perspective, but also for an overall well-being of the child. In terms of dietary assessment, we should be conducting a prospective minimum 3-day diet history when accurate, comprehensive information regarding dietary intake is needed. As noted here, although a diet history is preferred, a retrospective dietary recall over a 24-hour period may also be acceptable for dietary assessment. So if we look at the dietary intake, the 3-day diet diary based upon data in the non-CKD population has been shown with evidence that it's an unbiased estimate of energy intake in normal weight children less than 10 years of age. And most importantly, it captures the day-to-day variability in dietary intake. But not surprisingly, there may be underreporting in the adolescents because of the labor-intensive issues, if you will, involved with collecting information over a 3-day period of time. In contrast, the 24-hour dietary recall may be better suited for the adolescents, but it doesn't allow us to capture the day-to-day variability that the 3-day diet diary does. So for that reason, it's usually recommended to obtain 3 24-hour recalls, and ideally one is going to include not only a weekday, but a weekend as well to get the best assessment of the dietary intake for those children. In terms of biochemical assessment, we're recommending that we calculate the normalized protein catabolic rate, or NPCR, in adolescent patients on hemodialysis and utilize those trends to evaluate the dietary protein intake. And we should only be considering serum albumin as a measure of nutritional status once all other causes of hypoalbuminemia have been excluded. I've already mentioned to you that in the hypervolemic patient, they may be hypoalbuminemic. And in many of our kids, they may have inflammatory issues going on that also lead to a decreased serum albumin level, which negates its value as a means of nutritional assessment. But if one can rule out those other reasons for low serum albumin levels, then one can consider using serum albumin as one metric in the nutritional assessment. This is my last slide, again, addressing the issue of NPCR. This is information from Texas Children's Hospitals, where they compared children who had lost more than 2% of their weight loss for 3 consecutive months, looked at children and adolescents, and looked at the issues of NPCR and serum albumin to see which, if any of them, would be a valuable metric. When they looked at the adolescent patients and NPCR, you can see that those patients who lost weight over those 3 consecutive months or more had a significantly lower NPCR value than those children who maintained their weight. On the other hand, there was no difference in the NPCR values for the child-aged individuals on hemodialysis. When they looked at serum albumin in the adolescents, you can see no significant difference here in those who lost weight versus those who maintained weight. And in fact, when they looked at the younger children, the serum albumin value was higher in those individuals who lost weight in contrast to those who maintained weight. So the NPCR is an excellent metric to look at dietary protein intake, but at this point, it really should be reserved for those adolescents that are receiving chronic hemodialysis. And that is my last slide.
Thank you, Brad, for that very comprehensive review of the task force recommendations and the rationale behind them. And can I just remind delegates, if you have questions for Brad, please post them in the chat box, and we will address all of the questions after the presentations are over. Our next speaker is Caroline Anderson, and Caroline's going to be running through the practical guides that supports the clinical practice recommendations that you've just seen from Brad. Now, Caroline's the lead children's clinical renal academic dietitian at University Hospital Southampton, and she's also the improvement dietitian there. She has a long experience and has worked for 20 years as an advanced practitioner dietitian specializing in pediatric nephrology. She leads the clinical research and quality improvement team in Southampton and nationally. Caroline's completed a PhD in energy expenditure and requirements, looking at physical activity and body composition, nutritional intake, and nutritional status. So that puts her in a very good position to talk about the practical guide that we have just developed as a task force. Caroline has published several peer-reviewed papers, and she's a member of several UK organisations, PRING, which is the group of paediatric renal dietitians in the UK, the Kidney Quality Improvement Initiative, or QQIP, and also is involved with PEER, which is the Paediatric Innovation Education and Research Group. So Caroline, over to you.
Thank you, Vanessa. So I'm going to follow through, just check the slides are working, and talk you through the practical guide. And as Vanessa and Brad said, these were developed to support the clinical practice guideline recommendations, and they have a set format. And I'm just going to go through some of the key highlights of these documents. At the beginning of each of the practical guides, there is a set of clinical questions, and these are the ones that were used to develop the clinical practice guideline recommendations initially. And as you can see here, for nutritional assessment, we wanted to look at when nutritional assessment was needed, how anthropometry and dietary intake were assessed, can biochemistry be used to help nutritional assessment, and how does nutritional assessment influence patient management. Following on from this, we've developed flowcharts that attempt to summarize the key information in easy steps to follow. So for the nutritional assessment practical guide, there are 4 steps. The first one focuses on anthropometric assessment, looking at the primary measures, looking at the trends in growth parameters, and looking at the serial plotted measurements and any particular considerations for interpretation. Step 2 corresponds to dietary assessment and the key factors there. Step 3 corresponds to biochemical assessment, and step 4 to monitoring and reviewing. So if we just go through each of these in a little bit more detail. Brad has highlighted the key aspects here, but in this document we pull out the importance of each of the main parameters. So for weight, it is important that we look at euvolemic or dry weight, and there are particular challenges with overload and dehydration that we know with our children. Brad highlighted that it's important to consider the timing of estimation of your weight when children are on dialysis, and we also need to be take into consideration those that have high urine or sodium losses, because the measured weight might actually represent a dehydrated weight rather than an actual weight, and this might need adjustment. It's important that weight is also always looked at in the context of linear growth and proportionality, and Brad showed you the table that gives you guidelines of expected weight gain for the first 2 years of age. Moving on to look at length and height and tracking of growth. As Brad mentioned, Z-scores are important to complement growth plots on centile charts, and these are particularly useful at the 3rd and 97th percentile to give more detailed beyond these points. For children under 2, it is useful to use recumbent length for measurements and weight for length proportionality, and for children over 2, standing height and BMI for proportionality. As Brad mentioned, head circumference should be measured up to 2 years, but can be measured up to 3 years of age. And for those that plot with a height centile less than the 3rd, it's important to consider height age. Brad showed you the range of growth charts for WHO, and the recommendations in this task force were to use those up to 2 years of age, and then country-specific charts thereafter, providing there's validated and up-to-date information. If there isn't, then the continued use of the growth charts for WHO for older children should be used. Brad showed you the Turner's charts, and there are also ones for prematurity and BMI as he recommended, and other conditions such as Prader-Willi and Down syndrome. It's really important that we use serial measurements, so longitudinal measurements, and we look at the trends of these rather than taking a one-off measurement, and that we consider comorbidities. Moving on to BMI and body composition, Task Force recognise the importance of BMI in assessing over and undernutrition for malnutrition and adiposity, and highlight the changes in body composition. We know that these children can have a high fat to lean ratio and a low lean body mass, and muscle wasting can be related to lean mass wasting. We also know there are limitations with BMI, that they don't distinguish between fat, lean mass and fluid, and therefore this needs to be taken into consideration. And Brad highlighted the risks of using BMI with children of short stature who may have a normal weight, which may put them without a correction for height age into a higher BMI bracket. It's important to consider all the causes of growth and work with your MDT team to try and correct these alongside nutritional changes. Brad showed you the lovely U-shaped curve for the mortality risks of BMI at the extremes, and we also know that children at different stages of disease and different treatment can have different problems with BMI. For example, those on steroids or those with transplants that traditionally use the steroid protocols can have a rapid increase in BMI in the first 6 to 18 months post-transplant, but also there are pockets of children with transplants that can have a low BMI that need close attention. Brad highlighted the importance of mid-parental height in the assessment of linear growth, and it's important to measure accurately biological parents' measurements and then use these to assess current weight against mid-parental height. As you can see on the other side of the screen here, we've got some calculations in both the practical guide and the CPR that can show you the key calculations that are used, and Brad went through some of these in detail in his presentation. In terms of surrogate measures, for those children that can't stand, for under 3, the recommendation is to continue to use recumbent length, and for over 3, you could use demispan or ulnar length. Whilst these are not vastly researched in children with kidney disease, they have shown to have benefits, although there is a risk of underestimation slightly for arm span and overestimation for ulnar length. We've also provided an interpretation of the Z-scores for you to look at underweight and thinness and overweight and obesity. Brad showed you the table here for parameters and frequency for nutritional assessment, and this is really a guide and a minimum. We all know that these children can have problems with growth and nutritional intake and many other factors that cause growth failure, and it's important to use this as a minimum guide when assessing these children. Those that are younger or in end stage or have any abnormalities of growth and nutrition may need far more frequent reviewing. Moving on to step 2 and looking at dietary assessment, it's important to take into consideration all the issues in terms of nutritional concerns, dietary modifications that may have been made, for example, restrictions of phosphate or sodium or calcium or potassium, the appetite, diet quality, and portion size. But it's also important to consider the practicality. So can these children actually read and write and their families and record the information? What level of detail is needed in number of days in terms of the nutrients that need to be assessed? Energy intake can be assessed in far less days than some of the micronutrients, but that might not be practical. And also the time. Do the families have the time, and what's their burden of care like, and what is going to be possible? We recommend that prospective food diaries give the most accurate assessment, but if you're using these, they need to come with training and support for the families to help guide them with how to record accurate amounts, making sure they include brand names, preparation methods, and how to estimate and eyeball portion sizes. For those that are using recalls, it's important to use more than one recall, as Brad said, because this doesn't show the variability as good as the food diaries do. But it's also important that when you're assessing this information, you use language that doesn't mislead or bias the interpretation and the assessment. Food models and measuring devices or pictorial booklets can help with assessing portion sizes here and may be useful. We know with the advent of technology that the traditional food diaries can now be replaced with pictorial methods, electronic methods, including apps that patients can fill in. And whilst these haven't been extensively researched in children with kidney disease, there are small studies going on around the world. When we're looking at assessments, it's important to consider all different nutrients for excess intakes and potential deficiencies and comparison to requirements, and also any micronutrients that might have relation to abnormal blood values. Whatever is going on, it's important to also assess the micronutrient and trace element status, because dietary modifications and alterations in feed may affect this. Again, we have a table that Brad adequately showed you about the different frequency recommendations for assessment, but again, this is a minimum that may need to change if there are particular nutritional concerns. The guideline also highlights the importance of being able to use protein energy wasting assessments, monitoring gastrointestinal symptoms and appetite. The practical guide provides you with measurements of how to interpret protein energy wasting for children, looking at inadequate linear growth, BMI and MUAC less than the 5th centile, and any changes between these measurements in 2 points greater than 10%. We know that reduced protein energy wasting has an impact on quality of life, increased hospitalization and emergency visits, and therefore is important to assess. We know that gastrointestinal symptoms are common, and some of the key factors need to be included in assessments, and also that gastrointestinal symptoms can affect appetite and dietary intake. We also know, as Brad showed you, the importance of appetite, and this correlates clearly with quality of life and hospitalization, and has been suggested as a surrogate marker for nutritional status and well-being. Moving on to step 3 in biochemical assessment, it's important to look at nutritional status and intake in relation to any potential abnormal values of calcium, phosphate, serum, and potassium, and also to check that there are no procedural issues that may be providing these abnormal levels. The document highlights the importance of blood urea nitrogen and serum urea nitrogen and the potential for protein adequacy, but note that this can be affected by urine output, size, catabolism, and stage of disease. Brad showed you the table in the study looking at MPCR, so the highlight is to just use this in adolescents on hemodialysis only at this present time, but if you're using it to look at a marker of greater than 1 for an indication of protein adequacy. The document also highlights caution when using albumin for nutritional assessment, as this is affected by inflammation, infection, and fluid overload, which we all know all our children can have problems with. Moving on to step 4 and monitoring and review, it's important to look at all these factors, and the guideline clearly states that the requirements that we've shown you in tables 2 and 3 are minimum recommendations in terms of monitoring and reviewing these patients. But throughout each of the processes, it's important to assess growth, appetite, dietary intake, any modifications in diet and feed and supplements, any barriers to these intakes, any changes in medical management, presence of GI symptoms and activity levels. And it's also to look at this in the context of nutritional requirements. Are they meeting these requirements? Do any of these factors affect the requirements? And how are we going to tailor a plan to suit that individual? In the back of the clinical practice guide, we have secondary tools in an appendix focusing on the biochemical and the anthropometric measurements that may help support nutritional assessment. In terms of biochemical measurements, we've already mentioned the urea, acidosis and anemia and how they can be related to protein intake and growth potential. In adults, cholesterol and the prealbumin have been used, but they have found little value in protein energy wasting in children, and other markers need further consideration. In terms of the anthropometric values, there's a table 5 here that shows you each of the key parameters, suggested frequency, suggested stage and age of uses, and particular comments. So there is plenty of evidence for weight for height ratio and hand grip strength in research, but these have yet to be taken up into routine clinical practice. We have also provided some interpretation help here. So for weight for height ratio, a measurement of greater than 0.49 can indicate weight status, and this can be easily measured with standard operating procedures and a tape measure. Mid-arm upper circumference has a guideline of the less than the 5th centile for malnutrition, again has standard operating procedures of how to measure this, and has tables to compare evaluation. There are also tables available for hand grip strength and the association with looking at this as a proxy and a surrogate measure for muscle function and status. And there is information and data about bioelectrical impedance, but this is largely related to the dialysis population and looking at fluid status. One thing to note with some of these measurements, particularly bioelectrical impedance, that you need the equipment is very specialised, you need trained personnel, and you need to take serum measurements. And there's often more value in the raw data than trying to use the equations to compare these information at present. So in summary, for the practical guide, there are 4 clear steps that we go through when we're looking at patients' nutritional status and some secondary tools that might provide additional information to improve that assessment of status. We've also provided some links to the key standards and each of the documents that we've mentioned within the practical guide so that you'll have those at your fingertips if you need them. So thank you very much for listening, and I'll hand you back to Vanessa before she takes you through to the next stage.
Thank you, Caroline, for taking us through that practical guide. And again, just to remind you, if you have questions for Caroline on that part of the presentation, please post them in the chat box and we will address those questions towards the end of this webinar. And now I'd like to introduce our next speaker, Christina Nelms. Chris teaches nutrition classes through the University of Nebraska, and she has previously held clinical positions at many children's hospitals in Omaha, Oklahoma City, and most notably at the Children's Mercy in Kansas City, where she was a senior staff member. Chris has been the lead author for some renal chapters in very prestigious publications, the Aspen Pediatric Nutrition Support Care Curriculum, and also Nutrition and Kidney Disease and Pediatric Dialysis. She's also been chair in the past of PRONA, which is a North American pediatric renal nutrition practice group. So Chris is going to show us how we can go through a case study which illustrates the clinical practice recommendations that you've heard about, and also seeing how you can use the practical guide to put into practice looking after a patient by the bedside or in your clinic. So thank you, Chris.
Thanks, Vanessa. I am going to be discussing the practical side now that my colleagues have discussed the background information so that hopefully you can take the information you learned and think about how you would apply it to a typical patient of your own. So we're going to start with our patient case example. And in this case, a girl, Jill, is 3 years old with neurogenic bladder secondary to spina bifida, CKD stage 4, presenting to our clinic for evaluation. So I have a poll here for you. Again, it's time to put your thinking caps on, and audience participation involvement is required now. And so be thinking, based on what Brad and Caroline have shared, of which answer is correct. Which of these answers do you think would be most appropriate to collect on this patient at an initial visit? Okay, I think I'm going to go ahead and share the poll results now. Okay, and most of you got what I would consider the correct answer. 3 24-hour diet recalls. It's our first time of seeing her, so we want to collect some information right away. We want euvolemic weight. If she's got some edema going on, whatnot, we want to account for that. And as has been discussed, although appetite doesn't directly correlate to nutritional status, it correlates to outcomes and can give us a lot of clues about what might be important for management for this patient in the future. And it's a very simple parameter to collect, so it should be standard of practice to collect appetite. Caroline touched on the secondary parameters. So in development of the clinical practice recommendations, we determined that primary anthropometric measures are still our best tool. However, we looked at some secondary tools that are out there that have been well researched, and they are actually listed in the secondary tools by order of strength. So we decided as a group that although some of them had really good evidence to support them, that they should be secondary tools and possibly only be used for clinicians who are comfortable with them. For example, using hand grip strength requires special tools. It might require some practice or some skill to learn that. So those are things that can be used to help refine our assessment once we've used our primary measures that are outlined in the CPR. Now, pre-albumin is one of those secondary measurements that has some flaws, but it can provide some helpful information. Albumin is, again, should only really be used if we don't have reason to believe that it's skewed otherwise. This child is 3 years old, so we've outgrown a head circumference. C-reactive protein, again, would be more of a secondary tool. And a 24-hour usual intake, we discuss in the recommendations that any data you can collect on diet is helpful, but 3 24-hour diet recalls would be superior to a usual intake. But sometimes you take what you can get in a family that may not remember or whatnot. So moving on, just to review these answers, euvolemic weight, of course, is very important. Standing height is appropriate for this child at age 3, but a caveat, this child has spina bifida, so may not be able to stand. And Caroline discussed in our practical guide information about some of these alternate measurements that you can use to look at these kiddos. And given that she's still young, she's only 3, a recumbent length is probably going to be easiest to do since she's not much beyond that age where we would use a recumbent length anyway. We do need to note that lying down, gravity shrinks you, so to speak. So we need to be notating in our growth charts that this was a surrogate that was used, and that the measurement would actually be a little bit shorter if she were standing. Calculate BMI, as Brad discussed early. Inquiring about her intake, we can collect probably 3 24-hour recalls today, and if we're concerned, we can send home a 3-day food record. The frequency that we evaluate her diet will depend on identified risks. Inquire about appetite. At her age, there really is no great biochemical parameters. She's not on dialysis, so we're not going to have a PCR available. And again, albumin could be skewed. So we can look at measures such as BUN, for example, to try and trend that. But again, these are measurements that are not as validated as some of our primary anthropometric and dietary measures. So we're going to move to another poll now, and I'll give you a chance to look at these answers while I pull up the next poll. What considerations should you make when plotting her data? So what would you consider the best answer? Okay, I think I'm going to go ahead and close the poll. These questions I intentionally made a little bit tricky, so don't feel bad if you got the quote wrong answer, because there's a little bit of truth to all of them. But the best answer is A, calculate z-scores to complement growth plots. We know that that's a useful tool to visually see growth plots. Now, there's always a question of which tool is better. I would say the actual growth charts are still our primary tool. Z-scores provide really good data when we have outliers. So if we have somebody who is +2 for, let's say, BMI, that's a lot different than +4 for BMI, even though both would be considered greater than the 99th percentile. So certainly those Z-scores can be very useful. Weight for length, she's a little bit old for that. So she's 3, she's kind of just beyond that cutoff. Make plans to obtain monthly measurements. This is a great clinical observation that maybe this is needed. However, the guidelines would not quite put her at monthly for minimum measurements, but that would be a clinical judgment. My last question is sort of a tricky one. If she were less than the 3rd percentile, we would plot BMI for height age, but I made it 5th percentile just to be just above that. And honestly, that is sort of clinical judgment if her BMI needs to be plotted. If she's at 5th percentile versus 3rd percentile, those are awfully close. Who's to say we don't plot or consider it when somebody is short, just hasn't quite met that cutoff, but the guidelines do officially list the 3rd percentile as our cutoff for height adjustment. And there's some different literature that would support taller measurements, but based on the evidence and practicality, this is the number that the task force chose. Okay, moving on. Some things we need to consider using Z-scores to complement growth. Determining BMI for height age if she's less than the 3rd percentile, which we just discussed. And that graphic at the bottom shows Z-score curves. With the history of spina bifida, alternate means of height measurement very well might be needed. And one thing that's very important is we typically don't do a measurement, an alternate measurement as a one-off. We want to trend this. We would expect to plot the child the same way as long as reasonably appropriate to do so. Now, as she gets older, it may be more difficult to do a recumbent length, so we might need to switch to a demispan, for example. That might be more practical, but the important thing is because these surrogates can be overestimating or underestimating. We need to make sure that we're noting that it's a surrogate and trending, because the goal is to see if that child is trending up appropriately in height. Again, following trends. Hopefully this child may have data from other clinics that we can follow the trends. Otherwise, we need to start trending now, and we may want to see them more often depending on risk factors. So I just wanted to show you growth charts for this child. So as you can see, and this case study is a little bit different, whereas in a typical case study, you'd have all this information, but sort of the point of this case study is determining what you need to collect. So I did not share her weight and height measurements, but now that we can see that she is on the small side, that she's got some concerning anthropometrics, we might want to see her more often than we would otherwise. I just wanted to show you these as an example. Her weight is low, since we can see here that her height is also low. We've adjusted it back to where she's approximately the height of a 2-year-old. And so thus, when we plot her on the BMI curve, in this instance, typically it's the opposite, typically plotting back for a child of the age that is at the 50th percentile for height makes the child less at risk to be underweight, where in this case, she's actually a little more at risk, but she's still within normal limits. So her BMI is still proportional, but we are concerned about those poor weight and height measurements on the growth curve. So the last question, this is not going to be a poll because it was difficult to do. How often would you measure her anthropometrics and intake? And I just wanted to show you the table that shows, I pulled out from the table in the clinical practice recommendations what the minimums would be. And again, keep in mind that these are minimums. So again, it's going to be your clinical judgment, but this is a child that I might see monthly, for example. So just because she has those low parameters on the growth chart. And I just wanted to highlight here, we would use BMI for age. I wanted to pull out the whole part of the table. If she were 2, we would look at weight for length centile or SDS. That's why these are starred. They are depending on that age because they fall right at that cutoff when we switch growth charts. But this is a child that for most issues we would see every couple months. So we can go ahead and ask about dietary intake when we see her every couple months. And again, based on clinical judgment, we might be seeing her even more often. Okay, that is it for my part. And I believe that we are now ready for the question and answer session.
Thanks, Chris, for that very active and interactive session that's got everybody's brains going. And I'd like to welcome all of the panel to come now for our question and answer session. And we have a number of questions that we'd like to pose. And I think, Roxana, you're going to start with a question for Brad.
Yep. That's right. So thank you all. Very, very interesting talks. Brad, lots of interest has been generated by the NPCR discussion. And as you know, even as we sat down as a task force group, the Europeans don't use NPCR. So we were left a little bit, sort of not quite sure what you were doing across the pond. So would you tell us kindly, of course, the literature says NPCR is to be used in adolescents on hemodialysis. What does one do for younger children or for children with CKD or those who are on PD? Thank you.
Sure, thanks, Roxana. Well, I think most of the NPCR data was generated, again, as I mentioned, from Texas Children's, and showed the very nice correlation in the adolescent population to trend those values, and you can obtain those values as part of your routine urea kinetic modeling. So if you're generating your K2 over V, the NPCR can sort of be accompany those determinations. And again, it's not a single value. You're going to trend those values in the adolescents. We don't have the same data, if you will, supporting that for the younger children. Now, I don't think that precludes you assessing it in younger children, and again, trending it in that child just to make sure it's in the right direction. But we don't have data to support it, a value of 1 is indicative of an adequate dietary protein intake in the younger children. So in our own center, we certainly calculated for all of our kids on hemodialysis, but again, utilize that value of 1 in particular for the adolescent population. But it is part of our monthly routine, and I think in the U.S. It is pretty much a standard for the vast majority of pediatric hemodialysis programs. We don't have the same metric, if you will, in the PD population, and there's been some data historically looking at protein catabolism in kids on PD, but to be very truthful, it's not really part of standard of care in most pediatric PD centers. I mean, Roxana, you could comment from the UK perspective. Are you looking at, again, any kind of protein metric or dietary protein intake metric in the PD population?
Very good point, Brad. We don't look at we don't look at a particular metric other than the child's growth, their overall nutrition, and we also include serum albumin, keeping in mind that it's not a good marker, that it indicates inflammation as much as anything else. And we do look at albumin losses into the dialysis fluid, as well as the fact that there may be inflammation and that may affect the albumin. So putting all this together and excluding ruling out inflammation and ruling out any other causes for a low albumin, we would consider it as a marker, and we would increase the dietary protein intake to achieve a more normal albumin.
Yeah, and I think I was just going to say one other thing that I think most folks know who care for kids on PD is that when we're looking at the dietary protein recommendations, one has to always account for the fact that these children are losing additional protein across the peritoneal membrane. And so when you're calculating your DRI as far as for protein intake, one has to add, again, a value to address that loss through peritoneal dialysis.
Thank you. Brad, if I may just follow the same trend of thought with the NPCR. So we have a question that's come through who's asked if there's an additional benefit of calculating the NPCR even in adolescents on hemodialysis, over and above interpreting their growth, their nutritional intake as best as one assesses it, and their biochemical status.
I think all of that's complementary. There's not one single metric we should look at. We should look at the gamut, and it's part of the equation. So I think we use it to complement all the things that you mentioned to give us the best possible overall assessment of these kids.
Thank you. And this kind of almost takes us to a very nice new research topic for some young person with the energy to look at NPCRs in PD patients, and perhaps even look at it alongside their transporter status to see if there is the protein loss that makes a difference, and the overall picture on that. But thank you very much. Vanessa, over to you.
Yes, I think I'll direct this one to Chris, but of course, anybody else, please answer. And this is a question regarding looking after children with early stages of CKD, stages 1 to 3A, rather than seeing more serious cases in a tertiary centre. And the question is, in this kind of setting, which of the assessments in the categories that you've described, anthropometry, dietary assessment, biochemical assessment, which ones would you emphasize for the clinician in that sort of setting?
That's a great question. I'd like to repeat what Brad said, the more data you can gather, the better clinical picture you're going to have. I guess I would start with anthropometry. We know that the basic height or length, euvolemic weight measurements are our best tools, head circumference, if it's appropriate. BMI is criticized. There are limitations with BMI, but as of yet, it's our best tool that we have to assess proportionality. I think that we need to start with that and then use our clinical judgment to then evaluate further if there are additional factors. And I see that Caroline has some thoughts to add to this. So I would start with anthropometry because it's what we should be gathering on all these kiddos. But appetite, again, easy question to ask. And you can use a 5-point scale that's discussed in the clinical practice recommendations to have a quantifiable answer. And diet is perhaps a little more tedious if you don't have a lot of time. But again, I'll emphasize that any data you can collect on intake is going to be beneficial, because even if the child is getting an appropriate amount of calories, if they're eating chips and candy, that's not a quality diet. And one thing that the CPR emphasizes is also diet quality. We need to make sure they're meeting their micronutrient needs. So that's where I would start, but really any data that you can collect is great. And I'll let Caroline add her bit as a clinician as well.
So thanks, Chris. I was just going to reiterate what Chris said. In most children, we don't see the CKD 1 to 3 in clinical practice, but the measurements of anthropometry are assessed on all patients. So there is access to that information. And if there's some kind of screening for those at risk, then those ones that require more in-depth in terms of dietary assessment can perhaps be a level 2 that then could be referred to the dietitians for those in need. And appetite should be, as Chris said, something that could be is used in all clinicians' assessments. So even before the dietitian gets there, we can collect information on anthropometry, so weight, height, BMI, head circumference, or weight for length, depending on the age, and also appetite. And then from there, be able to develop that screening tool of which ones really need to see a dietitian, which ones, maybe need further monitoring for a month. But that helps that metrics, because we are all workforce strapped. And as Rukhsana said, not every country has a dietitian. So we want to use those dietitians in the places that they have the best need. But there are some very basic measurements that all patients should be assessed with. And that is the stage where the families are often most receptive. They want, they're newly diagnosed, they want to know what they can do to help their child. So it's an opportunity that we can really prevent ill health and make an impression. So we need to find some way of harnessing that information and using that as a first line to get to patients to say nutrition's important. This is what we're going to look at to start off with, but you may see dietitians and have further assessment and information later on.
And if I could just put in a plug for nutrition involvement early. Again, as Caroline said, resources aren't always there, but if I could just make a plug for getting good nutrition and dietetic involvement early, I think it may actually save work and physician time in the long run. I know when I would see patients for the first time when they're approaching end stage, they were train wrecks and they were overwhelmed by the diet interventions that I requested. But I made a big push in practice to be able to see patients early, CKD stage 2 and 3, because if I could establish that relationship, ease them into dietary restrictions, and get them in good shape before they progressed in CKD, it really helps. And who would you rather pay, a physician or a dietitian? Frankly, dietitians make a little bit less money. So if you think of it in terms of resources, that dietitian can be useful early on.
Thanks. This is a similar question, which is how to channel patients and information to the dietitian. We have a question from a staff nurse, and he or she is asking, what's the best way that they can help dietitians with monitoring nutritional status? So could you give some idea of how nursing staff can be involved here in channeling the right sort of information at the right time to the dietitian?
So, like adults have the must store, there are paediatric assessment tools that you can use, and some of these are embedded, particularly for inpatients, into their assessments that they come into hospital. So for nurses on the ward, that might be information that they might be able to pull together and put onto that system in the forms of identifying that risk. And if within your teams and your units you can assess a risk of what's the basic information that needs to be collected and what care plans need to link to those risks, that might help. In terms of outpatients and nurse specialists, collecting that information and asking about weight and length and head circumference and appetite, and then passing that information on to the dietitian can be really useful. And I know in the UK we all work very closely together, and the nurses will often collect that basic information for us when they have conversations with patients, and then pass that on to us in ward rounds or at team meetings or via email. I don't know, Chris and Brad and Ruxana, do you want to add to that?
I was just going to say, I think what you said is absolutely correct. But obviously every location is different, every practice is different, every hospital is different, and so I think the best thing to do is now with the tools that we've provided in this webinar is to have the team get together, be it the ward nurses, the dialysis nurses, the nephrology nurses, the physicians, get together and sort of say, well, here's our goal in terms of nutritional assessment. How do we best allocate the responsibilities, if you will, so that the child gets the optimal care? Because again, I think that the resources available at the various places will be different, but it requires a team for sure, and it requires communication, and then again, the allocation of responsibilities.
Absolutely.
And I also think if it's routine care and practice, that helps, because if it's collected all the time, that helps mean that when you can pick up those things, whereas if it's something you try and remember later on, it's less of a habit. So any habits that we can form and use these guidelines as the basis is a good starting point. Sorry, I interrupted Ruxana then.
No, not at all. I just want to follow on Brad's comment and actually answering some of the questions that have come through as well, to say that indeed nutritional assessment must start first. We value our dietitians as much as we value our clinicians, and our clinics include a joint doctor dietitian assessment, and this is particularly important for the youngest children in our infant or baby clinics, as well as for the patients with more advanced chronic kidney disease. One question for you, Brad. Appetite stimulants, would you recommend them?
Well, that's a great question. There's obviously limited data, and Chris and Caroline can speak to this as well. I have used them on rare occasions for those children who are not meeting their nutritional needs. But there is limited data in both the advanced CKD and the dialysis experience in children. So that's where my reservation has come about. But they, on occasion, they will work. Obviously, in the very youngest children, those that we're most concerned about, I think in 2021 compared to decades ago, we're all utilizing tube supplementation, be it gastrostomy or in some situations nasogastric, much more frequently than we did in the past to enhance their nutritional intake. But I think in the older children, there's going to be, have to always individualize care, and there will be situations when an appetite stimulant may be beneficial. Carolyn or Chris? Yeah.
I'll just add, there is only really one good paper that I know of that looks at megays actually in the pediatric population, and they had good results, but it was a small sample size, and one of their patients did have some cushingoid features, some side effects, and we certainly know that's true in the adult literature. So I guess the concern I have about using that particular appetite stimulant is we don't want to be adding fat mass to these kids. We want to be adding muscle mass, and really even our obese patients tend to be malnourished in terms of they have a high fat mass, low muscle ratio. So I think that's counterproductive to what we're trying to do. I know working with a physician, I've used a couple of the others with mixed success. I'm not going to mention them by name, but they work well in some patients and not as well in others. So I think we need to try some of those first interventions, enteral feedings, physical activity. There's a lot of data coming out about the benefits of physical activity. It seems counterintuitive when we're trying to get them to gain weight, but we really want them to gain muscle. There was a really nice brand new study that's published online but not available out of Egypt that I was just reviewing yesterday, that talked about the use of IDPN because in Egypt they were not able to access growth hormone or tube feedings as readily, and they had a lot of success with IDPN in improving lean muscle tissue. So I think that we need to look at some of these other tools and maybe perhaps appetite stimulants on a clinical judgment basis.
Thank you, Chris. I think, I'm sorry to interrupt you, Caroline. I think we'll have to wind up very soon now. We have a lot of other interesting questions about micronutrients, about phosphate, about the dietary assessment for calcium and phosphate, and all of this is covered in other webinars. So we do need to move on. Our guidelines are all available as open access, and you will be having regular webinars. You'll be getting more invites soon, and we hope you can join us there. Vanessa, over to you.
I just would like to thank our speakers very much, and Roxana for her introduction to the task force and our work. And as Roxana said, we have a very exciting program of webinars coming up, and Lucy is going to present those to you so that you can put these into your diary. So thank you everybody for taking part, and we look forward to seeing everybody again in about 8 weeks' time.
Thank you, everyone.
Thank you.
Thank you.
Bye.
So I'd also like to just say thank you to our speakers today for taking the time to present for us. And as mentioned by Vanessa just then, so this slide will highlight the 2021 webinar scheduled by the task force. So each webinar will cover a specific area of dietary management of paediatric kidney disease, and we'll use the same format. So we'll discuss the clinical practice recommendations and the practical application of each of them. So our next webinar will be focused on energy and protein requirements in children with CKD stage 2 to 5 and on dialysis, and will be held on the 15th of April. So we will get that invite sent out to you soon, so you can all get yourselves registered onto there. So again, just to finish, on behalf of VitaFlow, we would like to thank you for tuning in today. Please do take the time to complete the evaluation questions before you leave the session, and please remember to download your certificate of attendance as well. So on behalf of everybody today, we'd like to say goodbye and enjoy the rest of your day. Thanks, everyone.